Good morning. Welcome to Medicine Grand Rounds. Today we continue our lecture series on COVID-19, exploring medical ethics and their role in a disaster or pandemic. We are joined by one of our experts in medical ethics who will guide us through this topic, Dr. Jay Malone. As a reminder, please use the chat function on Zoom to ask questions. I will coordinate a Q&A session after the talk. I'll also have the QR codes for the maintenance of certification and CME. If I'm still waiting on the QR code for the CME, so if I don't get it, at the end, I'll just have everyone in attendance email me, and I'll keep a running list to forward to Kirsten so that everyone gets credit for participating. Dr. Malone graduated with his medical degree from the University of Oklahoma before pursuing a residency in pediatrics, also at the University of Oklahoma. He served as a chief resident before pursuing a fellowship in pediatric critical care medicine here at WashU. Most recently, he completed a PhD in healthcare ethics at St. Louis University. Currently, he's an assistant professor of pediatric critical care medicine and the medical director of ethics for St. Louis Children's Hospital. Throughout his career, he has been well recognized for his dedication to service and education that more than likely stems from his status as an Eagle Scout. He has won multiple teaching and clinical care awards during his time in residency, fellowship, and as an attending. Most notably, he won the Lloyd and Ruth Rader Award, which is presented annually to a single resident at the University of Oklahoma Health Sciences Center in recognition of great promise in research and clinical medicine. He has continued to live up to the expectations outlined in that award here at WashU through taking care of critical children and delving into the medical ethics associated with their care. It is my great pleasure to welcome Dr. Malone as he presents The Last Ventilator, Ethics in a Pandemic.
Thank you, Adam, and thank you for the invitation to be here today to talk about this, I think, very important topic, certainly one that many people have been putting a lot of thought into as the COVID pandemic has played out. I know people are getting a bit of fatigue with talks about COVID-19 in particular, but hopefully this talk touches on a lot of themes that are relevant to parts of our practice as physicians that have to do with things other than COVID-19, as well as the current pandemic. My only disclosure is that I receive speakers honoraria from an organization called the Fellowships at Auschwitz for the Study of Professional Ethics. I don't plan to discuss that organization in particular today. So to get at this idea of ethics in a pandemic, we're going to talk about the idea of scarcity as a concept. And I'd like to frame this story by using some historical examples of resource allocation and sharing some anecdotes that can help us to learn about how resource allocation has been done in the past. Certainly, we're dealing with these questions during COVID-19, but this is not the first time that the medical system has had to deal with scarcity of resources. And there's much to be learned from looking at historical examples. Then we'll talk about the principles of triage that are relevant in those historical examples and our current moment, and then pivot to talking about the crisis standards that have been developed in this region and across the nation during the COVID-19 pandemic to help us understand how we can best allocate things like ventilators, ECMO circuits, dialysis machines. Important to note here at the outset that we're not currently in a crisis phase of resource allocation. So we're talking about a hypothetical situation in which we might enter a resource limitation. And then we'll close with a few opportunities to move forward. This talk for me begins probably in a place that's not where you're expecting. I'm going to start in 1841 on a ship called the William Brown. The William Brown was a not very noteworthy ship that was used to travel between Europe and the United States, moving immigrants. And it launched in early 1841 from England, carrying a number of poor Irish and English immigrants hoping to go to the United States. And things were going well. They were about a month into their journey with only one death en route from disease, which was a great number at the time, when disaster struck. The William Brown hit an iceberg off the coast of Newfoundland, and a few minutes later it hit a second iceberg. And the crew realized quickly that they only had one lifeboat. So as fast as possible, the captain and the first mate moved as many people as they could into the lifeboat. That included the crew of the William Brown, but also many passengers, men, women, and children, as well as provisions of food and water for what was to come. The ship sank, actually taking most of its passengers with it, but leaving this one overcrowded lifeboat in the sea. Unfortunately, with the storm that was happening, the captain quickly realized that the lifeboat was overloaded, and he was going to have to make a difficult decision about who could stay in the lifeboat and who had to be thrown into the ocean to their certain death. This decision was made realizing that the only way that anyone on the ship would survive was if they made difficult decisions, triage decisions about who would go into the water. Ultimately, they decided that the crew of the William Brown would be allowed to stay in the lifeboat because they had purported utility in continuing to guide the life raft through the treacherous waters. They decided to keep women and children. The children didn't take up many resources or much space, and the women would be necessary to continue caring for the children. So the people that ended up getting cast into the water were the men who were passengers on the ship. And ultimately, the crew of the William Brown threw 16 passengers to their death in the ocean. One crew member was ultimately fined $20 for these actions. The remainder of the crew members went free, and the reasoning was that this was essentially the standard of care. It's what any sailing man would have done under ideal circumstances. The William Brown story is relevant because it has coined the term lifeboat ethics. And lifeboat ethics is this thought about what criteria could help determine who gets a seat in the lifeboat when not everyone can remain on board. Translated into our current moment and into medical ethics, this might be what criteria could help determine who gets a medical resource when there isn't enough to meet demand. Much of medical ethics has been framed around this idea of lifeboat ethics, or the ethics of scarcity. The resources we're talking about in medicine are things like space, ICU beds, hospital beds, stuff, the ventilators, ECMO circuits, dialysis machines. These are the things that we tend to hear most about on the news. Medications, new or existing, as well as PPE, and much has been said about PPE, and staff. Staff might be a critical resource that we need to ration at some point. When we talk about scarcity as a concept, I think it's important to note that when we review cases of scarcity, there seem to be at least two different types of scarcity. We could wind up in a situation of scarcity because a new therapy is introduced for an existing condition. Or we could end up in a condition of scarcity because a new condition occurs that limits availability of an existing therapy. There are plenty of historical examples of both of these types of scarcity. The first type, we might think of early vaccine development. In the early 50s, when ventilators were being developed during the polio epidemic, there were more patients needing ventilators than ventilators available. And in the early 60s in Washington State, when dialysis machines were being introduced, this was another example of a new therapy being introduced for an existing condition. The second type of scarcity we usually see around disasters, whether those are man-made or natural disasters. Certainly, they could be new diseases cropping up or outbreaks of existing diseases like measles, but we also see limitations of resources during things like the Oklahoma City bombing or 9/11, the Las Vegas shooting, or natural disasters like Hurricane Katrina. So I'm going to take a few minutes to look at an example of each type of scarcity as sort of an emblematic example of how triage decisions were made. So I'm going to just talk quickly about the introduction of dialysis machines and then about Hurricane Katrina as examples of each of these types of scarcity. The introduction of dialysis machines is an interesting historical example because we've got actually a great deal of really good reporting about this committee, which was actually made up of 7 people, though there's only 6 in the photograph. But a small committee was assembled in Washington state to determine who would get access to this new therapy of dialysis, which at the time was administered twice weekly for 12 hours at a time. So the people receiving it would simply sleep in the dialysis center while they were being dialyzed. The official name of the committee was the Admissions and Policies Committee of the Seattle Artificial Kidney Center at Swedish Hospital, but it later came to be known as the God Committee or the Life and Death Committee. And you may have heard it referred to as either of those things if you're familiar with it at all. The membership on the committee, the 7 members, were meant to represent a cross-section of society. And importantly, they were not the medical team who were taking care of the renal dialysis patients. So the composition of the committee included a lawyer, a minister, a banker, a housewife in the terminology they used at the time, an official of state government, a labor leader, and a surgeon. The God Committee, the Life and Death Committee, at some of their early meetings, decided to take up exclusion and inclusion criteria for who would qualify for this resource. So immediately they decided they wouldn't include children. They said treatment might cruelly torment and terrorize a child. Of course, we're talking about dialysis, which is something we do in children all the time now. They also decided to exclude what they considered older adults. That meant at the time, age 45. Sorry to many of the people listening to this talk, but they considered adults over age 45 to be too frail and at too high a risk of complications to undergo this unproven therapy. Then they considered things that they would take into consideration as they were deciding who was the best candidate. They announced that they would consider age and sex of patient, marital status and number of dependents, income, net worth, emotional stability, educational background, nature of occupation, past performance, and future potential, as well as names of people who could serve as references. So we can already immediately see that this is certainly different than how we might make these types of decisions today. We have nice records actually in some reporting from Life magazine, which was in its heyday in the early 60s, of sample committee proceedings. And I want to just show you some of these because I think they're, one, fascinating historically, but two, an interesting example of how the triage decisions were made at the time. So the lawyer says, the doctors have told us they'll soon have 2 more vacancies at the kidney center, and they've submitted a list of 5 candidates for us to choose from. The banker says, just to get the ball rolling, why don't we start with number 1, the housewife from Walla Walla. It says here her husband has no funds to make such a move to Seattle, near the dialysis center. The minister says, how can we compare a family situation of 2 children, such as this woman in Walla Walla, with a family of 6 children, such as patient number 4, the aircraft worker? The housewife says, if we're still looking for the men with the highest potential of service to society, then I think we must consider that the chemist and the accountant have the finest educational backgrounds of all 5 candidates. Surgeon says, how do the rest of you feel about number 3, the small businessman with 3 children? I'm impressed that his doctor took special pains to mention that this man is active in church work. This is an indication to me of character and moral strength. The labor leader says, we've got to reckon with the surviving parent's opportunity to remarry, and a woman with 3 children has a better chance to find a new husband than a very young widow with 6 children. These conversations show us a window into a historical version of triage that seems very foreign to us now, but we can take away that they were utilizing personal, perceived moral characteristics because there was an absence of good medical data by which to make these decisions. And ultimately, they did make decisions on the basis of things like income, net worth, number of dependents. This is an image of one of the recipients of dialysis with his children. So what can we learn from this proceeding, which is so different than how we might operate things today? Well, first of all, the committee didn't pick particularly bad goals. They wanted to benefit the most patients, and they wanted to do that by selecting what they perceived to be good candidates. Certainly debate could be had about the manner in which they determined who was a good candidate, but the goal of benefiting the most patients seems reasonable. They also wanted to benefit society by selecting patients with social utility, which is why they considered things like education and job performance. Further, there was a strong desire to avoid burdening society. So they actually prioritized patients whose deaths would leave financial or childcare responsibilities. So when I first read that this committee looked at income and net worth, I made the assumption, as many of you may have, that they were going to prioritize people with high incomes and high net worth, but quite the opposite. What this committee did was to suggest that people with a high net worth were likely to have made accommodations for their family in the event of their death, and therefore their death wouldn't leave a societal burden. So this committee gave preference to people with lower income and net worth. In the reporting in the famous Life article, the author actually said that were one to desire to maximize their chances with this committee, one approach might be to father a great number of children and throw away all your money. That was the sort of approach that this committee was using. It is typical, as in this committee, to have limited knowledge of emerging therapies. And we still see this today, that as therapies are being introduced, we don't quite know exactly what the medical indications are. This was how they treated moving forward with dialysis in the early 60s. Certainly, we wouldn't think now to exclude someone because they were over age 45 from receiving dialysis. But because they didn't have medical indications, the committees left using non-medical personal qualities as indications of who might be a good candidate. So that's something to carry forward when we think about how to allocate new scarce drugs like remdesivir, which we'll talk about later in the talk. Remember, I mentioned before that there's two sort of scarcity types, and the God Committee represents the first type of scarcity, a new therapy for an existing condition. But that second type, the new conditions that interrupt established therapies, often occur after disasters. And so we're going to shift now to the triage that happened after Hurricane Katrina at Memorial Medical Center. And this was a very different type of triage that can teach us different lessons about how this played out. Memorial Medical Center is a medium-sized medical center, but they unfortunately had generators in their basement. And so when the levees broke in New Orleans in 2005 and the city was flooded, those generators went underwater. The hospital quickly lost power. So the people left in the hospital not only didn't have environmental services like air conditioning, they also found themselves unable to get patients out of the hospital because of the floodwaters surrounding the building. And the conditions were terrible. The temperatures were in the 120s and it was very humid. People were left caring for patients with very limited both medical supplies. They didn't have power to run ventilators, for instance, but also limitations of food and water. So the medical staff were really without much training in disaster management and triage, decided to sort people into categories. To sort is actually the meaning of the word triage. The French word trier means to sort. And that's exactly what the physicians and nurses at Memorial Medical Center did. They decided that category 1 patients would be those in fairly good health, able to walk. They received first priority for evacuation. Category 2 were patients who were sicker in need of some assistance. They received intermediate priority. And the category 3 patients were those who were either severely ill or actually those who had pre-existing DNR orders. They were given the lowest priority. And you can't see it in this picture, but if you zoom in further on that picture, you can see that the man on the ground has DNR 3 written on his hospital gown. So the staff at Memorial Medical Center communicated priority categories to one another in this sort of crude but efficient way of writing the triage ranking on the patient's gowns. This is also typical of triage or disaster medicine because it lets other providers know very quickly the status of the patient. So ultimately, over the 5 days that played out at Memorial Medical Center, The category 1 patients were able basically to walk or be helped to an ambulance bay, and they left by boat. There was a major effort to mobilize boats in the New Orleans area to get people out of these buildings. The category 2 patients were left with sort of a cumbersome process. They had to be taken to a parking garage and pass through a hole in a wall to a fairly steep set of stairs that led up to a helipad, where they were over a few days evacuated by private helicopters. The category 3 patients have generated the most controversy after these events played out, because the category 3 patients, many of them were euthanized by the medical staff using morphine and midazolam. As this played out, the head physician who was in charge of this process was charged with 10 counts of second-degree murder and conspiracy to commit murder, although a grand jury ultimately did not indict on any of those counts, so no charges were ultimately pursued. But this received a lot of national attention, and you can get more information about this in a wonderful book by Sherry Fink called 5 Days at Memorial, which gives a great description of the way these triage decisions were made. This looks very different than the triage that was done for dialysis by the Seattle Committee, and there are different lessons to be learned, but the goals are interesting to compare, because similar to the dialysis group, the people at Memorial also wanted to save the greatest number of people possible. They did that by directing resources to those people most likely to survive. They also, and this is where the controversy came in, that they decided to alleviate suffering for those very unlikely to survive, and the manner in which they did it is where the controversy came in, by active euthanasia. But the goals, the basic goals of directing resources to those most likely to survive and providing palliation to those who aren't allocated to resources in order to save the greatest number of people possible, these are the general goals of triage medicine that we carry with us today, 15 years after this event. It's also important to point out from Memorial that in the midst of the crisis is the most difficult time to plan for the crisis. Once you're in the crisis situation, once the crew of the William Brown is in the lifeboat, that's not the time to figure out the problems that systemically resulted in the situation. But it's also not a great time for the medical providers to be figuring out how to handle the situation. In this case, at Memorial Medical Center, the physicians had little to no triage training, and so they were left really to make these sort of ad hoc decisions just based on their own reasoning. It's also important to point out that as this played out in the media afterwards, the greatest concern from the community was lack of decision-making transparency. It was very unclear to community members as charges were being brought and people were coming to grips with having lost family members under these circumstances. It's very unclear how the team had made the decisions that they made. And so one of the messages from Memorial Medical Center was that it's important to clearly articulate the manner in which decisions are being made so that that can be communicated during the crisis and after the crisis. Also important to note that physicians were not free of legal scrutiny. They were also not indicted ultimately, but it is for this reason also very important to articulate what the crisis standards of care will be. If that can be done ahead of a crisis, even better, because they can undergo legal review ahead of time. But crisis standards of care help to establish the standard of care by which physicians should act. And so in theory, having a well-developed crisis standard of care should help to provide some legal immunity for physicians acting under that crisis standard. We also reiterated, we probably already knew this in 2005, but most hospitals lacked crisis standards of care. And there was in fact very little national agreement about appropriate triage decision-making criteria. That unfortunately still largely remains true. As we entered the COVID-19 crisis, we found that even after Memorial and H1N1 and a number of other crises, that many hospitals lacked crisis standards of care. So what do we even mean by crisis standards. What are the ethical standards that we pursue in crisis? Well, in normal conditions where most of us have always practiced, the full range of indicated medical therapies are available to every patient. You can think about an emergency room at BJH. Patients who come in with the most severe illness and injury are treated first with all of the force of our medical technology and availability of resources. And we're able to do that because of a surplus of resources under normal operating conditions. We can wait to treat patients with less severe illness because we know that they have more time and we have enough resources ultimately to treat all of those patients. But when we go into a crisis, the obligation shifts from the individual patient to a public health ethic, which is focused on the overall societal good. An idea of, with limited resources, how can we best direct those resources to help as many people as possible and do overall good? Now, you could debate what overall good means. Does that mean number of lives saved? Does it mean number of life years saved? Or even quality adjusted life years saved? There's many ways to think about how to quantify the overall good, but most experts agree that the goal shifts so that we're looking for some version of what's meant by overall societal good. Physicians, individual physicians, unfortunately, are not generally trained to shift their thinking from individual patients to populations. So when we let physicians get into a situation like what happened at Memorial Medical Center, where they're making ad hoc decisions with little training, it's very difficult for individuals to shift their thinking from individual patients to populations. We can also see that limitation in resource implies a change from that normal provision of medical treatment to what we call an altered standard of care or a crisis standard of care. And as demand increases for medical supplies, we move along this continuum from conventional therapy to a contingency status into ultimately a crisis as resources become more limited. For much of the past 2 months, we've been operating in this middle zone of contingency. And many of you will immediately recognize that staff have been asked to work different shifts, some longer shifts, some staff have been furloughed. There have been different configurations of where different types of patients are admitted. Notably, we had some adult patients admitted to the ICU at Children's Hospital. That is a contingency measure meant to preserve resources and share burden. Ultimately, the standard of care may begin to change in contingency, but doesn't fully switch over to crisis because patients get functionally equivalent care. All patients ultimately get the care they need, even if it may be delayed. In a crisis, we wind up with more patients than available resources. So this is when we may see the actual rationing of select supplies and therapies. And in this condition, we switch into a crisis standard of care. That's when we might have to triage to sort patients. So how do we even approach this? What do we do? Well, many hospitals, as I've already mentioned, began developing crisis standards of care in 2009 following the H1N1 flu pandemic. The H1N1 flu pandemic impacted about 20% of the world's population and was, many of you recall, a major health crisis. This one was also much more highly prevalent in pediatrics, and so many of us on this side of the street also can recall treating a lot of children with H1N1 disease, which was very serious. Unfortunately, after the crisis of H1N1 passed, the impetus to continue developing policies and come to consensus and continue contributing resources to development of policies began to dwindle after the initial crisis had passed. So while many hospitals began developing these crisis standards, many didn't complete that work. So a lot of hospitals were left with sort of partially developed crisis standards of care that hadn't reached full consensus among the affected people. At the same time, during this development process, based on lessons that we learned from Katrina and H1N1 and many other crises, Fukushima comes to mind among others, some cities began to engage their communities in a discussion about how best to triage. And the thinking there was that the public bears the consequence of these decisions. When we talk about public health ethics, we're talking about how to do the most societal good. I mentioned that you could debate what that societal good means, and one way of getting to that answer is to ask society. The public's values in that way are central to choosing among these sort of multiple valid different triage options. It seems that ultimately a successful effort would require public trust and cooperation. We don't do our communities very much good if we end up breeding distrust in the medical community more than that which already exists in many areas of the communities we live in. It's also important to note that knowledge of public perceptions helps to prepare authorities to communicate, and that means both governmental authorities but also hospital leaders. And by understanding what different patients and community members might perceive as important factors in triage, we can understand how best to communicate with the public. Also important to note that while we can do some work to develop crisis standards in a crisis, having in-depth deliberations with the public are simply not feasible in the midst of a pandemic. And so doing this type of work, either immediately after a pandemic when things have settled down, or before hopefully the next pandemic arises, is the best time to do this type of work. So one of the cities that did a very interesting job of engaging the community was Baltimore. And in Baltimore, this group led by Elizabeth Biddison engaged two communities with very different demographic profiles, East Baltimore and Howard County, to participate in focus groups to deliberate about two questions. The questions were, what should we do in situations where there are more patients needing ventilators than there are ventilators to use? And should healthcare providers ever be allowed to remove a ventilator from one patient who needs it to survive and give it to another patient who also needs it to survive? These two communities they picked, East Baltimore and Howard County, are similar to something like North City and Ladue. East Baltimore, notably at the time, was having an influx of immigrant residents. They also have a high population of residents with felony criminal records. Howard County is the most affluent county in the area, perhaps in the whole state, if I'm not mistaken. So very different communities. And these researchers were interested in how each of those communities might respond to these questions differently. They set this up by presenting possible triage committees to the different communities. And I want to share the principles that they presented to the communities because it's a good overview of some of the possible principles that we might use and still engage today to perform the work of triage. So, right, under normal operating conditions, our standard practice is first come, first serve. That makes sense when there's a abundance of resources, when there's no scarcity, because ultimately everyone will have availability of resources, even if you give them to the first people to arrive for them. So in first come, first serve, patients are simply given ventilators or other resources in the order in which they're diagnosed until there's no resources left. You could use a lottery. All the patients who need healthcare services are assigned a number. Healthcare providers select a random number and they give the resource to the patient with that number, a simple lottery. You could prioritize those most likely to survive. If you understand the disease process well enough and the way that the therapy works, you can evaluate which patients have the best chance of surviving their current illness. Of note, this research was done specific to flu and ventilators, which is why some of these descriptions reference those things. But patients with the best chance of surviving their current illness would be given priority over those less likely to survive. You could prioritize those with the most years left. This both probably means younger patients, but also patients who don't have any comorbid conditions or underlying illnesses that might shorten their lifespan. So if a patient has widely metastatic end-stage cancer and a life expectancy in the months, that patient might get less priority than a patient with no comorbid conditions. A little bit different than life years is the concept of life cycles. Life cycles is giving priority to patients who have lived through the fewest stages of life from youth to old age. This differs a little bit from life years because this really isn't about looking at underlying illnesses or likelihood of ongoing survival. It's looking at the amount of survival that's already happened. So if you used strict life cycles or fair innings, a child, even if that child had some life-limiting disease, would be given greater priority than an adult with no life-limiting disease because of the principle of fair innings. You also could look at value to others in a pandemic. This is the idea that perhaps patients most likely to have an immediate impact on society, like first responders and clinicians, would be given priority for medical goods. So these two communities were asked to consider those triage mechanisms in relationship to the two questions that had been posed to them. And inner city East Baltimore was most concerned with equity and treatment of particular groups, like felons and immigrants, the two groups that I mentioned there were high numbers of in this community. The researchers also noted that the participants emphasized the importance of transparency and clarity with regard to both which criteria were being used and the rationale behind them. Suburban Howard County, on the other hand, was most concerned with logistics. The participants in this group didn't seem particularly concerned that they wouldn't get the life-saving resources. They just wanted to know how it was going to play out in a practical way. So a very different impression of what was most important to think about from these communities. Many participants in both groups favored incorporating more than one principle, developing a multi-principle priority approach. And that might mean something like making an initial estimate of chance of survival, but then further delineating which patients qualified for treatment on the basis of something like life years. And participants talked about different combinations of approach. Differences emerged, of course, between the two counties, as I've already mentioned. For instance, in Howard County, the majority of people thought that we should give priority to those most likely to survive. Well, that wasn't the breakdown of answers in inner city East Baltimore. This likely because the folks in Howard County understood that their baseline health conditions were good and they would be judged most likely to survive. The most contested and highly problematic principle was value to others in a pandemic, and there was no consensus in either group about whether that should be considered. There were concerns that the people writing the policies, healthcare workers and hospital employees, might use this to benefit themselves. There was also an instrumental concern that it might be important actually to spare the people who are critical to a pandemic response, although it became clear that it's very difficult to define precisely who is critical to a pandemic response. Opinion also varied widely on removal of the ventilator, and no consensus was reached on this, with some participants suggesting that that was akin to murder, and some suggesting that that was absolutely vital to making these procedures and policies work. Ultimately, the authors noted, importantly, that people's moral perspectives on medical practice emerge from what they have experienced and learned about the world, including relations of inequality, and not simply from abstract high-order values. This might not be a big surprise or a sort of earth-shattering observation, but it is a really important one. I'll just point out before I move on that one of the middle authors on this article, Doug White, has been instrumental in developing model hospital policies for use in the current pandemic, and his work has been greatly influenced by this earlier work. So we're going to come back to him in just a moment. So here we are now at COVID-19. And COVID-19 is interesting because it presents us nearly simultaneously with both types of scarcity that we've been discussing. We have a new condition that's overwhelming existing resources. There have been reports in the United States, but also around the world, of shortages of beds, vents, dialysis, PPE, staff, etc. At the same time, we have that second type of scarcity, where we have new, largely unproven therapies that are being used to treat the prevalent condition. So things like remdesivir, which is currently being made available through allocation programs by Gilead. Hopefully there will be a future vaccine released to treat this disease, although we would anticipate that if a vaccine is released, it will initially be in short supply as well. So here we have one situation where we have both types of scarcity. The goal in both cases is to maximize the benefit available from the limited resource. But achieving that goal, as we're going to discuss, requires different approaches in each case. You can't use the same approach to both of these types of scarcity, as we've seen from our historical examples. I'm going to talk for a minute about the framework that's been adopted most widely in this country to identify how we should ration critical resources like ventilators and critical care beds, but also dialysis machines, ECMO circuits, etc. A model hospital policy was released in Pennsylvania based on work by Doug White, who I mentioned a moment ago as a middle author on the Baltimore study. And this model policy has now been adopted by hundreds of US hospitals, several state governments. It's been endorsed by the Missouri Hospital Association. It's also been endorsed for use in our region, although it's been modified somewhat. It was important as we were developing crisis standards of care for this area that we not allow patients to go to one hospital and receive very different care from the care they would receive at a different hospital. We didn't want one patient to be declined for a ventilator at one hospital when they would have received one at a different hospital. And so a great deal of effort went into unifying crisis standards of care across the systems in our region so that St. Louis would have one unified policy for how to deal with rationing. The model policy that I'm going to discuss is the policy on which that was based. And it's a really good example of a triage approach to shortages of critical medical supplies like ventilators. This policy, like what was suggested in Baltimore, uses multiple principles to decide who is a best candidate for critical care resources. So based on the impetus to save the most lives, mortality is assessed using sequential organ failure assessment scores in adults, PLOD scores in children. And in order to understand how to save the most life years, comorbid conditions are taken into account. So in this system, a patient receives a score, which could range from 1 to 8. And based on that score, patients are placed into priority groups. Those priority groups use a color scheme that's sort of standard to normal triage nomenclature. But patients with the lowest priority score, meaning the lowest number of comorbidities and the lowest SOFA score, are given the highest priority for receiving healthcare resources, and that's to ensure that we're saving the most people possible. Patients with more comorbidities and a worse presenting SOFA score receive the lowest priority for healthcare resources. And I want to highlight a couple important aspects of this type of approach. First of all, there are no categorical exclusion criteria. People tend to cringe a little bit when we talk about things like excluding everyone over a particular age. This was used as sort of a blunt tool in Italy during their crisis response when they restricted ventilator use to patients under age 65 and later under age 60. This particular policy recognizes that that type of approach is unlikely to capture true estimates of benefit. And so all patients are at least assessed for candidacy. This policy importantly uses triage teams to make decisions rather than having bedside clinicians decide who does and does not qualify for care. This is important for a number of reasons, One is that it's the most fair way to do it. Asking bedside providers to make individual decisions is a easy way to introduce bias into the triage decisions. Asking bedside providers is also a quick way to generate a huge amount of moral distress as bedside caregivers experience discordance between their duty to individual patients and their duty to carry out the public health goals of triage. We mentioned before that individual physicians are not very good and they're not trained to switch between those two modes of thinking. This policy also describes procedures for reallocation of critical resources. This was a controversial element of the community engagement study in Baltimore, but ultimately, if we have patients languishing on ventilators with low likelihood of survival, when there are other patients awaiting those ventilators, it makes the most sense in terms of our goals of public health ethics to reallocate those resources. That's done in this process through frequent reevaluations of priority scoring and reassessment of priority categories. Importantly, this policy does not consider a number of factors: race, ethnicity, gender, sexual orientation, religion, insurance status, education level, immigration status, and national origin. And it does allow for tiebreakers if patients have the same priority score, priority category. There's a lot of different tiebreakers that you could use. Most of them tie back into one of the triage schema that we discussed before. So you could use something like life cycles, status as a worker critical to the public health response. Pregnant patients could receive higher priority. Ultimately, you could use a lottery if you've used many tiebreakers and the patients have still maintained equivalent qualification for the resource. There are, of course, some remaining controversies about this type of approach. First of all, it's not clear to many people whether life cycles are discriminatory on the basis of age. People have varying opinions of whether that's the case. Many thinkers have said that life cycles are different than simple age discrimination because in this case, people who have lived through more cycles of life have already received a resource, the ability to live through life, that other people haven't received. And so priority can be given to people who have had less opportunity to live through the cycles of life. But again, this is a hotly contested subject. The idea of healthcare workers or workers critical to the public health response is also highly controversial. We could think about this in terms of utility of people who are likely to be helpful to the ongoing public health response. But some people also think of it in terms of reciprocity, that healthcare workers have taken on a great deal of risk in caring for patients with COVID-19, and they're in some way owed something by the medical system. It's not clear how the public will respond to this criterion. Frontline healthcare workers and other individuals like food service workers and municipal workers have been hailed as heroes widely in this crisis. But after the crisis has passed, it remains unclear how the public would respond to operationalizing this particular criterion. It's also very important to me to mention the impact of disparities on a process such as this one. And it's important to point out that this policy attempts to enact procedural fairness by treating everyone equally. And people talk about the idea of a rising tide lifts all boats. But what we've seen as COVID has played out in our communities is that many of the boats in the community have holes in them. So as the tide rises, people don't actually receive equal treatment. Equal, in a sense, is not the same as equitable. If you put people into a policy process that treats them all the same, but they're starting from very different starting places, ultimately, the social determinants of health that have contributed to the underlying differences in health condition will be amplified by this type of process. That is a very difficult problem to recognize and to account for in the midst of a crisis. But it is important to point out that this is a real feature of many of these policies. There's also another issue that we probably could spend a whole hour talking about. I won't, but SOFA scores utilize creatinine, which we recognize to be different at baseline in African American patients than in Caucasian patients. In theory, by considering these patients using the same cutoffs for creatinine score, we could be disadvantaging people of color by using creatinine as a marker of kidney disease. It's not clear in practice, based on what the cutoffs are in the protocol, that this would make a huge difference, but certainly the possibility remains, and the optics of this are not good. So a lot of thought has gone into how to adjust the protocol and adjust SOFA scores to account for that. I'm going to shift for just a moment. I know we're getting near the end of the talk, but I want to shift to that second type of resource scarcity, and I want to talk about it in terms of remdesivir. Remdesivir, of course, is the novel antiviral drug that has been released as a potential treatment for COVID-19 disease, although there's currently no rigorous evidence to guide assessment or risk. And so the model policy approach that we've been discussing, the multiple principal allocation that's based on risk of mortality, can't apply. The reason for that is that risk factors for poor prognosis, those things that are used to allocate ventilators, don't necessarily predict response to new therapeutics. So while we know that an older individual with coronary artery disease is at high risk from COVID disease, that doesn't necessarily mean that that person won't respond, and perhaps respond the best of anyone, to remdesivir. So it's impossible to use the model policy approach fairly to allocate this type of drug. We also shouldn't use first come, first serve approaches because, as I've mentioned previously, they disadvantage those with barriers to care. So in absence of data to guide allocation, in this niche example of remdesivir, random lottery is actually the fairest allocation method until we can get rigorous evidence to guide assessments of benefit and risk. As soon as we have that data to guide assessments of benefits and risk, we need to change our response to how to allocate this drug. But for the time being, many ethicists agree that random lottery is the fairest allocation method. The co-author with Doug White on the JAMA article describing ventilator allocation was Bernard Lowe. Bernard Lowe was the first author on a second JAMA publication describing allocation of remdesivir, in which he echoes this sentiment that random lottery is the fairest allocation method. Like ventilators, allocation assignments for remdesivir should not be made by the team caring for patients. So the lottery should be carried out by someone other than the bedside providers. So what are our opportunities moving forward as we close out the talk here? Well, first of all, many healthcare systems around the country have opportunities for transparency. This is difficult in the setting of an ongoing crisis, as I've mentioned, but moving forward past the crisis, there are opportunities to work on messaging internally and externally to communities about how we might do this if we're ever faced with this situation again. There are opportunities to engage with community advocates and to involve community leaders in discussions, the same way that Baltimore did several years ago. And so after the dust settles from the COVID-19 pandemic, there are real opportunities to participate in this work. That leads to an opportunity to actually engage in deliberative democracy, just like Baltimore did. St. Louis has its own community dynamics that are in some ways similar, but in many ways different from what existed in Baltimore. The broad social awareness of this type of event is now heightened by COVID-19. And so it would be important for us as an institution to engage with communities in understanding what their preferences would be. That will enhance our ability to provide transparent communication to those communities. And Washington University is well positioned for this because of the incredible public health resources that we have at the Brown School, people who are very invested in this work already and can provide invaluable information and resources going forward. So we've talked about ethics in the lifeboat, of how we make these decisions when we're already in the crisis, but moving forward, we have to attend to the ethics of the lifeboat. Why did the William Brown only have one lifeboat in the first place? For COVID-19, those questions are things like, why are there national shortages of ventilators and PPE? Why are African Americans infected and dying at disproportionately high rates? Those questions of the broader socio-demographic contributions to the ethics of care are so critical for us to address going forward. It's hard to address them fully in the midst of the crisis, although we can start that work. But as we move forward as an institution and a community, we have to continue attending to the ethics of the lifeboat so that the next time we're in the lifeboat, we have a better answer for the crisis at hand. So I'm going to stop there, and for the last few minutes, I'd be happy to take any questions.
Thank you very much, Dr. Malone. Give me a second right here. I'll pull up the QR codes for everyone. Okay, and with that, the first question I have for you is, should triage decisions for ventilators be the same for all technologies like dialysis, ECMO, medications, or should they be individualized based on the technology?
I think that's a really important question, and important, of course, in the sense that we have to think about how to allocate all these different technologies, but we're also seeing that ventilators actually were not the first thing that we were likely to be short of. It was more likely to be something related to dialysis, actually, dialysis fluids. I think one of the things that's important is that the overarching themes of how we do the resource allocation should be thought of similarly. For those well-established resources, we should think about our opportunity to save the most lives with the resources. We should think about how we can save the most life years. For particular resources with different medical indications, the manner in which we assess potential for benefit from those therapies may well be different. That gets a little bit complicated because for each individual therapy, you might have to think differently about risk of mortality. But if you really wanted to do this in a refined way, you would want to consider the individual indications for each therapy to try to understand who was most likely to benefit.
Okay, follow-up question. How should we address disparities in access to technology in small community hospitals or rural areas compared to tertiary care referral centers?
That's not exactly a softball question, is it? It's
Not particularly.
It's so, you know, the things that we can do right this moment to think about equity in care are often things that have to be done at a leadership level or an institutional level. Some of those things are things like offering support to smaller hospitals. Certainly in our system, we should be providing technical support. An example of this that I would offer is that BJH, of course, and many of the larger hospitals in our system have access to things like infectious disease consultants or renal consultants who can help to weigh in on these policies. Many of the smaller facilities won't be able to, for instance, use an ID service to help allocate their remdesivir. As an overarching organization, BJC can centrally offer some resources to smaller places to help deal with some of those problems. The other thing that I would suggest that can be done in an immediate sense to ensure equitable care is that while I implied that you can't fully solve the problem in the midst of the crisis, there is no reason that we cannot begin the process of transparent communication with our communities. And certainly at this very moment, we have an opportunity where, yes, we're anticipating that there might be a second wave of COVID-19 patients. Right now, we're in a relative lull in patient volumes. We have an opportunity now to reach out to community leaders in different areas of the St. Louis region and more broadly to understand preferences related to these questions, but also to just begin the messaging process and to talk to people about what we are doing to ensure that care is equitable. So the process of engaging those conversations is, I think, a really important first step that it's never too soon to start.
All right, and then in the interest of time, I'll end with a question from myself. So you brought up a lot of points with the different major events such as the Oklahoma City bombing, Katrina, and the H1N1 flu. I guess my question being, having trained in New Orleans and kind of seen how everything revolved back around the events of Katrina, it seems like that event was pretty ingrained in the memory there, but perhaps certain things around the country maybe not remembered so much. I guess my concern being, how does something like this, how do we take our experiences with COVID-19 into making future decisions like these, with the fear being that you brought up with the H1N1, that perhaps some of these decisions and discussions weren't taken forward as the pandemic wound down.
Yeah, thanks for that, Adam. I do think that's a major concern. And, you trained in New Orleans and saw sort of the relics of Katrina. I trained in Oklahoma City and certainly saw the community memory of the Oklahoma City bombing. I was in Oklahoma City when that happened and certainly saw the memory of that play out in the medical system there in terms of the way that they planned for future disasters. But you're right, communities who weren't hard hit or weren't directly impacted tend not to put as much stock into remembering those things. COVID-19, I think, might play out a little differently because it has so shaken so many aspects of our society and created such a huge impact on nearly every community that I'm hopeful that we might be able to maintain the momentum that currently exists in generating ethical, equitable policies to address these problems moving forward so that we at least are better prepared the next time something like this happens. As you're pointing out, communities like New Orleans and Oklahoma City experience these local tragedies and then use those to prepare because they're hard hit. While it's unfortunate that so many communities have been hard hit by this, perhaps we can use that as an impetus to carry this work forward.
All right. Thank you so much for a fantastic talk, Dr. Malone. We appreciate you taking the time to come talk with us today. For everyone else, we're going to continue Grand Rounds next week. So same time, same place on Zoom, and we'll see you then. Again, thank you, Dr. Malone.
Thank you.